So Dr. Prashanth Srinivas is a medical doctor and he's a public health researcher at the Institute of Public Health in Bangalore, where he heads the health equity cluster. His research is primarily focused on health inequities and the social determinants of health. As an intermediate fellow of the DBT Wellcome Trust India Alliance, he set up multiple collaborations to examine health inequities in indigenous communities in many remote forested locations in southern, central, and northeast India. In fact, since 2014, he's been living and working in a tiger reserve in BR Hills in southern Karnataka, where he's been working with the Solega tribal community, specifically researching what he calls the transformative dimensions of technological solutions to address health inequities. Very recently, Prashanth won 2 major grants from the India Alliance. The first was the Team Science grant named Coincide, where he leads the qualitative study that aims to comprehensively assess the impact of multiple adverse exposures on children's neurodevelopment and mental health. The second is the Clinical or Public Health Research Center grant in the same year. So big congratulations on that, Prashanth. One of the objectives of the center grant is to assess the impact of substance use and abuse in tribal communities on children's health and development. So in a way, his work brings together the research interests of 2 groups within Sangath, the addictions research group and the child development group. And I'm sure a lot of the group members present here will be interested to hear more about your work. So we look forward to hearing about your work with the tribal communities, what you've learned from them, and how you've been setting up the next stage to facilitate and ensure equity in health for these marginalized communities. So over to you, Prashanth. And again, apologies for starting late.
Thanks, Devarti. Am I audible and is my first slide visible?
Yes, yes.
So this is really an interesting day for me to share this work and how it connects to work that is going to begin in the next few years. Before I begin, I just want to convey my sincere thanks for the trust placed by several Adivasi and scheduled tribe communities in the work that we started in 2017 under what is called as the Theta project, which you will see in red, towards health equity and transformative action on tribal health. So this was part of a clinical and public health fellowship awarded to me in 2017 by the DBT Wellcome Trust India Alliance. I would like to particularly acknowledge a deep sense of gratitude to the Nishi people around Pake Tiger Reserve in Arunachal Pradesh, Baiga and Goan communities that worked with around Kanha Tiger Reserve in Madhya Pradesh, Paniya, Katanayaka and Kuruchia communities that we worked in northern Kerala, Wayanad, and most importantly and consistently for the last 5 years, we have been closely working with the Jenukuruba and the Soliga Adivasi communities in southern Karnataka, around 3 protected areas. So these communities.
Hi, Dr. Prashanth. I'm very sorry for interrupting you midway. So, Smita, are you here? There are people waiting on the Zoom link who are waiting for the webinar to start there. Should we ask people to move here or move people from here to Zoom? I'm so sorry, Dr. Prashanth, for interrupting you, but there seems to be a little bit of confusion ongoing.
Since Prashanth is on this link, I wonder if we should call everybody to this link so that transitioning to Zoom doesn't create more problem.
That's fine. We'll just do that. All right. Thanks.
Thank you. So, I wanted to begin by acknowledging these several Adivasi and tribal communities who allowed this kind of work to happen with them. And secondly, we had the work I'm going to present is as with many research projects accomplished through collaborations and teamwork across a range of individuals and organizations whom I have acknowledged on this slide. The main work that I will be presenting to you is part of what we do in the health equity cluster at IPH Bangalore, which examines one primary unit within the cluster, examines the drivers of social inequities that impact health of Adivasi communities. Now, there's a lot that can be said about the word tribe, and in fact, when I shared the poster and the talk, today's talk with many of my colleagues, many people were pointing out about what does it mean to be tribal, because what is often understood when we say tribal or tribal health is the idea of scheduled tribe, and this is a statutory category. The government designates several communities as a scheduled tribe, and this is of course part of constitutional affirmative action policies that we have. But beyond that, the idea of who is a tribe and who, for example, are Adivasi communities. In some parts of southern India, there are other designations called Girijana, mountain people, for example, and various other sort of identifiers that communities use to self-identify. And one common kind of a historical phenomenon that all of these communities talk about is land and political and social exclusion of various kinds that they have faced over decades, if not in some instances over centuries. The most recent work at the global level was this study that put together the largest data set of indigenous communities. By the way, indigenous is another label which has its own social, legal, and technical contestations as to who is indigenous and who is not. And unfortunately, it's beyond the purview of today's talk. But for the sake of simplicity, I will be referring to communities that we worked with as variously as Adivasi in the case of tribal communities that we worked in Central India and Southern India, and scheduled tribe in the case of Northeast India in Arunachal Pradesh. So this phrase used by Anderson and others in a commentary that they wrote in the Lancet about about the health inequality pattern reported at a global level across indigenous communities is really basically captures the current health situation. They said behind everyone, everywhere. Of course, this does not mean anything beyond the fact that the health related gap that we are able to measure through our data reports that their healthcare services and healthcare access and healthcare entitlements are the ones we are talking about when we say behind everyone, everywhere. And this is the case with most of the communities that we work with as well. And I think to understand and actually, build a research agenda around health inequalities or health inequities, there is a very important need to be able to integrate wider social, political, and theoretical understanding of why communities tend to struggle with respect to attaining their health-related rights, health-related entitlements, and things like that. And with many Adivasi communities, especially in Central and Southern India, the very big problem is the difficulty that we see between reconciling national priorities related to biodiversity conservation and people's priorities with respect to seeking health, education, community development, etc. And so there's been this really sort of I mean, many of us hold that this is a false kind of a contrast set between saying, okay, in case tribal health, tribal education needs to improve, then they have to be removed or brought closer to quote unquote civilization. And I mean, it's a strange way of constructing disadvantaging communities by calling them as being far away from civilized. And there's a whole lot of critique about this way of framing framing entire communities. But if you look at the last 10-20 years of literature, what it tells us, including public health literature, it has this lens, this gaze of looking at entire communities, especially tribal, as being less civilized or being far away or being too distant. And I think it's very important to try and understand where this comes from, this idea that there is one mainstream, and that physically bringing out Adivasi people from where they have their roots and they have built their indigeneity can actually be seen as empowering. I mean, it seems, when framed this way, it seems obviously disempowering to ask people to come closer to cities in order to attain health, education, and development. But that's been an important reason why our programs, policies, and everything has centered around problematizing their physical location. And I think this is more than just an intellectual or a conceptual problem. It has very real world implications. Take, for example, several tiger reserves in the country which have been built without settling the rights of people who have always lived there. So boundaries were drawn for conservation purposes, and suddenly many Adivasi communities became foreigners on their own land where they were extremely well rooted. Now, the reason I bring this up is because when we build a research agenda around why is a certain community having poor health indicators, we immediately locate our research agenda on technical issues. Okay, maybe for example, if you do a survey, obviously educational status will be predictive of poor healthcare access, and it's no shock or surprise that it will be the case with tribal, or it will be the case with any community. But then to then say that okay, it's because they are less educated that they have less health is deeply problematic. And in this paper in the center, a recent open letter that we wrote, some of us tried to cite several examples of different communities that are disadvantaged socially, politically, economically, at saying that we must move beyond problematizing individual behavior and individual attributes as being deterministic of why their health, their individual or familial health status is poor, and we must look at quote unquote the elephant in the room, the larger macro social and organizational and institutional factors that are actually perpetuating and aggravating disadvantage of various types. So what we did in the team is to build this kind of a research agenda that tries to ask different types of questions, and not and especially so on the right side is for example one schematic that we had prepared for this reader on HPSR, Human Resources for Health, and I mean it can be something that is useful to look at systemically any problem actually. And we took this kind of a multi-question or multi research question typology lens, and we brought this onto the idea of Adivasi health. And if you see, sometimes it's the questions that it's through improving our questions that the research agenda can be made more meaningful. For example, on the top right is emancipatory questions. So can we, for example, frame our research questions in ways that can problematize social inequalities, in ways that can involve communities in trying to address or understand or theorize on their own issues. and a lot of work advanced by social scientists, by participatory action research practitioners, etc., helps us move beyond in this direction. So in the Theta project that I'm sharing here, we try to look at these three questions. So that's what the talk is centered around: patterns, process, and action. And by patterns, of course, we meant epidemiological, quantitative health inequalities, which we did through surveys and fairly familiar techniques in public health. We used wider theories on which are already available, which social scientists and various Adivasi scholars, feminist scholars, and various other scholars who have looked at how social inequities get perpetuated. We tried to integrate them into theorizing around Adivasi health inequities. Sorry, I'm getting a buzz noise. I don't know whether it's only me. Yeah, thanks. So that was the second objective on
Prashanth, I'm sorry, but you've been muted.
Okay, thanks. Yeah, the second one was on theorizing around using some of these wider social science theories in our work. This was largely qualitative. And a third objective, which was participatory, which was co-production. I mean, you can use many of these many buzzwords, which mainly indicate that you try to how should you say, you ultimately you try to try to share the power that, I mean, it's not like researchers are the most powerful people on the planet, but whatever sort of convening authority we have as researchers, how do we share it in a wider circle such that we can bring about some kind of sustained community action on the issue of Adivasi health. So this really was, and this is how I've structured the presentation: patterns, process, and action, and of course very quickly outputs and next steps. On the patterns issue, the protocol, which is on the right side and it's available on Welcome Open Research. The idea really was, if you look at NFHS data, you have fairly good data on what is constructed as the ST, the scheduled tribe. Now there's a big problem with this, as with all sort of categories. There is a very heterogeneous group of communities which have been statutorily granted the scheduled tribe status, who all belong in ST. And obviously, I mean, living, if you looked at the states we worked in, Kerala, Karnataka, Madhya Pradesh, and Arunachal, just imagine, I mean, those of you who are familiar with some of these states, being an Adivasi in northern Kerala, being an Adivasi in southern Karnataka, being an Adivasi on the fringes of Kanha Tigerism in Madhya Pradesh, and being a scheduled tribe of Arunachal, are very, very different experiences of the health system. Yeah, you experience very different administrative arrangements, you experience very different social connections, gender issues, food, everything is very different. So unfortunately, we do not have data. And in fact, the high-level committee on tribal health that was headed by Abhay Bang and various other people with who have worked for decades on tribal health, largely in civil society, but also in governments, they have already identified this as an important problem, that the fact that we aggregate all our data on very heterogeneous communities under this category ST, and this is a big problem. So one of the things we tried to test here is at a very fine scale. What I mean by that is, if you take protected areas in northern Kerala or in southern Karnataka or in Kanha or in Pake and Arunachal, if one is if there are tribal households, and there are also several non-Adivasi and non-tribal households around these parks. So what really is the difference? Because NFHS tells us differentials at state level, and now from NFHS 5 we get to know district level differences, but it is still an average and there's a whole half an hour we can discuss on NFHS methods, but the sampling does not allow us to make any assertions with respect to disadvantage or development status or healthcare indicators of specific tribal communities. So that is something that we sought, and we created our study design to allow this kind of hypothesis testing at a very fine scale, at a protected area level. On the left is our field station in BR Hills. It's a tiger reserve in southern Karnataka, where it was really the headquarters of the work that we did. We set up very similar field stations, some of which were long term, but some of which were very short term. For example, in Kerala, my colleague Sabu, I think, yeah. So, for example, in Kerala, my colleague Sabu here set up a fairly 3-4 year field station in northern Kerala. In Madhya Pradesh, the engagement was very short. We were, you could compare us to these global health parachute researchers who go in and go out with a very specific project. So we have done that as well, which is certainly a big problem to do community engaged research in the parachute way, and we unfortunately had to do that in Madhya Pradesh because we didn't have a long-time collaborator. But in Arunachal, we worked with ecologist Nandini Valio, who has been working for decades there, and we sort of piggybacked on an ongoing ecology research work that she was doing, and Julie, who's now doing her PhD, then joined us and led the field work there. In Karnataka, of course, I showed you our field station. So it's me, Tanya, Yogesh, Nitya, Mahantesh, and others who were ourselves on the ground and leading the field work. So in this manner, we covered this one. For example, on the previous one is in one of the households in Karnataka. Here is a Soliga Podu. Podu is a hamlet of the Soliga people who are an Adivasi community in southern Karnataka. Kadakal Kindi, one of the hamlets where we were doing community consent. Gajagadi, a Katanayaka, who were one of the particularly vulnerable tribal groups in Wayanad. Baijalpur, a Gond village in Madhya Pradesh, and Nere, a Nishi village belonging to Nishi scheduled tribe in Pake Tiger Reserve, Arunachal. So the tool, I will not go into these kind of details, but we basically had a tablet-based device to capture data, and it was geospatially characterized such that we could, for example, if you look at, I don't know whether my cursor is visible, but on the bottom left, this longish shape here is BRT Tiger Reserve, which is about 500 odd square kilometer, and you have settlements well within this protected area and outside. And for those of you who are not familiar with tiger conservation and tiger reserve regulations, these are very restrictive laws which suspend, I would say, historically unjust laws which have suspended rights, basic rights and amenities of several Adivasi communities in central and southern India. And only in 2006, when the Forest Rights Act, which is a bit more enabling legislation, came, were some very basic land rights granted, and it's a long process and a long struggle that for example, the Soliga Abhivriddhi Sangha, the social movement of the Soliga people, continue to this day. So if you see, some of the hypotheses here were around trying to understand whether if people move out, if Adivasi communities move out closer to these very dense red dots, which is what is considered quote unquote civilization or mainstream, etc., does the situation really improve? Yeah, right? I mean, because that is the assumption under which most of conservation laws and a lot of public health programs and policies are also based. The idea is that you move people towards health centers, hospitals, and then we believe that their health and health status improves. So the data allows us to look at this. So in total, I won't describe this table, but just to give you a sense of how many villages we covered. We covered totally 217 settlements constituting about 1200 odd scheduled tribe and Adivasi households, with several individuals within each household whose data was characterized. We are in the process of reporting some of these results. Sorry, it's heavily raining here, so you might be hearing this noise. But we looked at so currently some of our colleagues, my colleagues Yogesh, Julie, and others are leading small pieces of work that will characterize these fine scale inequalities within each state between tribe and non-tribal communities. And of course, the core hypothesis of how do healthcare access and outcomes vary with respect to remoteness is something that is still ongoing, and I will not be presenting it here. But I think in the next few months we hope to be able to share that. We also, as in the sidelines of this, we also did some secondary data analysis from NFHS 5 data to look at to look at a bit intersectionally where ST urban versus ST rural children does, for example, those tribal communities who move towards cities, for example, do they get the quote unquote advantage of being closer to health and healthcare and health sectors, etc. So this was a piece led by Sabu, one of our research associates. Another component we looked at is sickle cell disease, and that is ongoing work that is led by Deepa Bhatt, our collaborator, and we hope to characterize also dyslipidemia and NCD risk factors in the southern Karnataka population, where we looked at lipid profile and other NCD risk factors. Particularly here, one thing to be shared is the idea of, the use of tobacco and alcohol. In many parts, we found twice the level of tobacco use among tribal communities, and nearly twice the amount of alcohol use as well. And the pattern is very different. With many Adivasi youth, what we found is early initiation, sometimes in early teens, and much more harmful use, the pattern of alcohol. So this is something for which very little culturally and socially appropriate interventions are currently available to address this issue, especially in many Adivasi areas. So that sort of summarizes the quantitative component. That a lot of it is still ongoing, and we hope to share it soon. So in the process component, we try to understand why and how are systems failing tribal health, as opposed to just services, and in health systems we make a big distinction between health services, which is all of private preventive, promotive, curative services that are delivered through organizations with human resources for health and things like that, and systems, which includes governance, financing, and the overall way in which the administration of factors that contribute to people's health is organized. So in this second objective, what we problematized enormously is the very heterogeneous nature. So a lot of this work happened. It happened mainly in southern Karnataka, and we tried to integrate what is already known and written about by several social scientists who have been inquiring into land-related exclusion, various other social and political exclusions that Adivasi communities face. So one of the reasons why we felt it's very important to push back and question the idea of geographical isolation is because if you look at governments, state governments and Ministry of Tribal Affairs and many of the government policies, invariably the easiest solution they come up with is, for example, mobile health units. So they say, okay, tribal communities are living very far away, so we need to send a jeep and a health team. And what problematizing geography makes is it creates solutions that are not very how do you say? I mean, this doesn't. I mean, mobile-based camps having several dole outs of services which do not take into account the cultural specificities of tribal communities, do not really end up impacting their health status. Take for example the COVID-19 time itself, where many of the communities that we were working with did not feel safe in isolation centers that was set up, and many of them would not get tested, and many of them would not avail of vaccination later. So a lot of the issues that we believe are being faced with respect to why tribal communities health status is poor also has to do with historical relationships between them and the state. So currently a lot of the relationship is built on the idea of distance, and we try to build an argument through various through some of the stuff that we're going to present on how there is a need to engage with this idea of historical relationship, and hence there is a need for trust building. There's a need for embracing ideas around cultural safety in making services feel safe for communities, and in also acknowledging discrimination within healthcare services. Discrimination often need not present in very frank ways of discriminating based on an Adivasi identity. Sometimes it's merely about not being aware of what is an Adivasi person expecting when they turn up at a distant district hospital, and what kind of a healthcare environment would be more welcoming. Sometimes it's things that we do not know, and why do we not know? Because we believe that these have not been problematized sufficiently in academia and in universities, etc. So we of course did this review on top on the right, where we synthesized various current social science understanding of why health of indigenous populations is worse off, and we made this kind of a framework on the left is an adaptation of the social determinants of health framework of the WHO, where we try to problematize the idea of adverse forest regulations and adverse relationships between the state, capital S state, capital S state, and the Adivasi. So one of the components, ongoing research here, one of the PhD students that I'm supervising, Anika Juneja, is examining how neighborhoods also accumulate disadvantage. It's not only that disadvantage accumulates within households and attributes of individual household members, like for example, you say, okay, this household has an alcoholic father, or okay, there's a lot of tobacco smoke inside. So these are all, for example, household level factors that cause a disadvantage perhaps for the children. But what about neighborhoods? Why do neighborhoods remain disadvantaged? Why don't roads go to certain neighborhoods and they go elsewhere? Why doesn't water supply go to certain villages and they go elsewhere? So how do you problematize these and try to understand why neighborhoods become impoverished? And invariably these are structural factors. These are not rooted in individuals' behavior. So we try to advance this, and Anika is looking at two sites, one in southern Karnataka and another in collaboration with Janswastha Sahyog. She will be looking at a site in Chhattisgarh and Madhya Pradesh, where she will try to understand how this impacts the experience of sickle cell disease and sickle cell crisis among two different Adivasi communities. Again, another ongoing work by one of the students I'm supervising, Meena, where she is working with Mahadevamma, who is a Soliga Adivasi woman leader, as well as one of our colleagues at the field station. And together we hope to try and understand how patient rights and the idea of patient rights, what does it mean with respect to Adivasi patients who are care seeking? What do they understand by rights, and how do they practice it, if at all? And also how adverse healthcare experience. I mean, I can go on for hours about the adversities many individual Adivasi patients face when we refer them to tertiary care, despite the presence of Ayushman Bharat and various other health insurance policies, etc. Accessing them still remains very difficult and mired in bureaucracy, which is very tough to navigate from the worlds from where many of these patients come from. So this is also theorizing around this is also ongoing. Meena, in fact, has a very interesting paper that will come very soon in BMJ Global Health, where she tries to understand how bureaucratic power of the state is plays out when aggrieved individuals try to ask for their patient rights, and she uses a case study of women who died during hysterectomy in northern Karnataka. So this was a bit of the action, and I'm aware of time, and I think I'll take another 5-10 minutes, Gauri, to also go through action. But if I'm going beyond time, please feel free to interrupt.
No, please go ahead. You know, Prashanth, we've started a little late, and at least personally, I'm absolutely fascinated by this work. So please do continue. We'd love to hear more.
Sure. I think I will wrap up in 10 minutes so that we can also, I mean, I'm giving a sense of them so that we can also hopefully have some discussion and go deeper if needed into some aspects. So in terms of action, there are two components, you know, and I think for those of you who are familiar with participatory action research, which comes from this idea that of action and reflection, which needs to happen iteratively. And so the reflection component of our PR practice, I intellectually was very stimulating for me and my team, because we try to understand how can we reflexively look at our relationship with the Soliga Abhivriddhi Sangha. So the Soliga Abhivriddhi Sangha, for example, is a community-based organization of the Soliga people, and they are one of the partners. In fact, Dr. C. Madegowda, who is the secretary of the Sangha, is a collaborator on Theta as well. So he's a PhD in social work, and he's done enormous research, and of course leading here, and he's of course part of the Soliga social movement, and has been instrumental in trying to organize around the idea of forest rights and securing their forest rights. But for us, what was very important was to try and understand how is the relationship between academics like us when we take on this kind of community engaged partnerships and CBOs like the Sangha. How does that relationship play out with respect to power? You know, who has power over what, and what kind of questions can communities ask? What kind of change can they make within us researchers? Because ultimately, true participation, I mean, true or, I mean, okay, maybe it's not a question of true and false about participation, but rather a continuum and pushing the boundary of this participation ladder. As a tangent, for those interested, you can look at this Arnstein's ladder on citizen engagement. It's a very nice framework that people have used to try and reflect, okay, how participatory is my whatever it is. It could be a citizen science project that is looking at birds. It could be a global health project. It could be something like this, or it could be anything. So how do you try and understand how participation worked or did not work? What are the kind of spaces that got created, and who created these spaces? Whose voice is able to reach that space and whose voice not? So these are the kind of questions that we tried to ask. And very interestingly, this researcher who was looking at ethics and justice, Bridget Pratt, she was earlier with the Nosal Institute of Global Health. She had reached out on an email discussion group asking if there's any group that wants to work with me on reflexively looking at their relationship with the CBO partners. And we used that opportunity to have this case study, which led to these 3 papers. All of these are, I think, available online if you Google them. And I think we learned a lot in just academically reflecting on the idea of how spaces are created and how voices are heard or not heard, and who is at the table and who is not, even within a small community setting. we were able to suddenly witness and see and experience exclusions that happen at various steps. And this really informed our practice in terms of the action component. So that was more the reflection part. So the way I've divided, sometimes it's also difficult. How do you report on PAR projects? So these three were the outputs of the reflection component that we did in course of about 24 to 30 months of participatory engagement. What did we do? So the idea was really, action on tribal health or action on health inequities. I think it's very difficult for small groups of research, small NGOs or initiatives like ours to meaningfully impact at scale. So we decided that we'll try to learn and understand this at a very smaller level. And broadly, this was the kind of spectrum that we looked at. Okay, how can our actions impact social institutions and structures, which is the furthest and the most tough to impact. Somewhere in between meso level is how can we impact health and healthcare organizations and their practice, that is the institutional and meso level. And of course, at the micro level, how can interventions affect neighborhood and material circumstances? And you will see all of these are coming from the wider framework of social determination of health. In the case of the neighborhood circumstances, we literally chanced upon through various engagements, through various community meetings, and conversations, the problematizing basically youth and young people, because the survey was also showing a lot of tobacco use and alcohol use among young people, harmful use, early adoption, and hardly any meaningful service available for cessation, because we also did not, and I think it's very important within addiction work to also not moralize about this issue, because there is a lot of work around the need to carefully navigate addictions in a way that is empowering to the person receiving these services. It's not a moral issue, but it's an issue of individual Adivasi youth being able to have a control over their health. So in that sense, we, instead of creating cessation services or medical services, we said, let's try and have youth clubs. For various reasons that I won't go into, volleyball we started with one volleyball club, and there are now 13 volleyball clubs in across 11 villages. Of course, gender has been an important barrier. Only 2 of them are have a good number of women. 11 others are all male clubs. But it's a beginning, and these clubs over the last 1.5 year gave us confidence that this larger framework of sports and mental health, or sports for wellness, could become an entry point in future. So this was one space which is about clubs. And then second is we said, let's try and have another space, which is an indoor space, a library. So within one of the community halls that belong to the Sangha, and Samudaya Bhavana, it's called in Kannada, community hall, which is in one of the settlements called Banglipodu. We started this Doddasampige Adivasi Granthalaya. It started as a library space, but it has become a rich kind of cultural space where study circle style dialogues and debates happen sometime. So and there's an ambition to eventually have discussions like this on tribal health and theorize around these in smaller groups in these kind of public spaces. But that's still an aspiration. On the right here is some kind of an evolving program theory on how these clubs could be working, and this is something that's ongoing. Further visuals from there. We also do once in 3-4 months, we do small competitions across these clubs to try and bring people together. At the institutional level, we tried this healthcare navigation, where an Adivasi social worker could be positioned at taluka and district hospitals, a person who is aware of the social circumstances from which patients are coming, who can then help them navigate them through these kind of schemes, be it Ayushman Bharat or various other schemes. Sometimes it's, so the reason this was taken up is literally being present in the in the district. Almost every day we were spending triggering social networks for organizing care for families. So in some sense, this intervention systematized the kind of social networks that we were triggering as researchers. So how can we kind of bring that into the system? Can a social worker then try and do this? So this we tried at a very small scale, and we felt it is very much relevant and successful. And just a few weeks back, I'm happy to share that the Karnataka Health Department has begun working on a plan to pilot this in multiple districts in southern Karnataka to see whether this will improve accessing care for Adivasi populations in these districts. And one of my colleagues, Yogesh, is working on a national task force grant that he got in course of this fellowship. And he was able to try and see how we can improve care for hypertension and diabetes, because a lot of our survey work was showing a fairly high prevalence of NCD risk factors. So how do we, in remote tribal populations serving PHCs, how do we improve culturally appropriate care, and how do we meaningfully involve panchayats in these areas, especially panchayats in Adivasi areas, in problematizing NCDs and in improving access to diabetes and hypertension. So that is that became its own project, although it had its origin within Theta. And I think most importantly, we found Sushila and Madesh. Sushila is currently doing a PhD in social work in Mysore University, and is from the Koraga Adivasi Sangha. Koraga are another community who are a particularly vulnerable tribal group in Karnataka, and she worked with us and has now become a policy engagement point person within our team. And Madesh from the Soliga Sangha. Both of them, we built their capacity to be able to engage directly with policymakers, particularly the Department of Tribal Welfare in Karnataka. And I think this for me is the most successful kind of partnership, where we are hoping that in a sustainable way, they both will be a liaison between research team and the Soliga and Koraga social movement, which have their presence much beyond our research agenda. Another extremely important thing where I think researchers like us learned something important is Madegowda and the Sangha, Soliga Sangha, taught us that forest rights and rights over land are at the very core of Adivasi health and well-being. So, and you can see that this is not at all problematized within public health literature. And currently, through Theta project, the Sangha conducted and sort of rejuvenated 117 forest rights committees across 117 hamlets in Chamarajnagar, and very carefully and systematically they are learning the Forest Rights Act, and they are carefully and systematically making use of that law and trying to obtain everything that they can with respect to securing their rights. And these rights are very basic. This is about, for example, having a road to your settlement. It's about having piped water. It's about getting the electricity department to come and provide electricity for your settlement, and these are not there now. And one of the primary reasons is because our tiger conservation laws, which are very important. I really love birds, and I do quite some work on. I work with several ecologists on conservation issues, but there has been this false dichotomy created between keeping our forests pristine, which is seen as an aspiration which is often achieved at the cost of the rights and livelihoods of several Adivasi communities. So we saw this intervention as impacting social institutions and structures. Of course, Adivasi individuals are much too vulnerable to be able to shift structures, but when they have these kind of movements, they are able to galvanize and they are able to leverage this kind of power to push back against adverse kind of situations. I won't go into this, but because of our presence there, we were able to meaningfully also support more culturally appropriate COVID care during the epidemic. And those interested can look at at the left bottom is this India Forum article on that we wrote with Mahadeva, who's the president of the Sangha, on culturally safe care for COVID during COVID times. There are several intermediate outputs from the fellowship. The core quantitative outputs are still awaited, and I hope in the next coming months those will also be available. But we had some kind of tangential outputs that came out of it. Some other work that continues because we are in a tiger reserve, and so we work at the interface of ecology and social science. So we did some work on One Health. Within One Health too, the idea is that we bring this historical and social perspective into this kind of One Health research, because One Health has become fiercely biomedical. It's largely about zoonotic diseases, but One Health is also about people's lives and lives of people like Adivasi communities who live in and around protected areas. So we try to do that. The reason I put this is something that I should have perhaps declared at the very beginning. I am not from an Adivasi family. I am from a generationally privileged family in Bangalore. And so in course of this work, I think one of the things that became very evident is the reason I think we often do not problematize social inequities enough is because often we don't accept them. I think many of us are stuck in this debate of how everything is about individual grit and determination. Everything I achieve is because of my hard work, or I was great, I was good, it's my merit. So I did a reflective editorial examining this idea of merit that is that's almost like a firewall among the privileged, and it often prevents us from meaningfully engaging, I think, in many of the debates and difficult questions that many people from social movements and activists ask us about. So that was also kind of an output of the work that was ongoing. I won't explain this, but I think I have benefited from a vast number of collaborators, colleagues, and mainly PhD students who joined this journey in course of this fellowship, and networks, various networks that we were able to build. There's the last two slides. Devarati mentioned at the very beginning the center grant. So as you must have realized, the many of the threads that I opened in the presentation are unfinished. So you probably were thinking, okay, what happened with the volleyball clubs? What happened with the idea of remoteness and its analysis? A lot of this will be consolidated in the center grant that thankfully allows us to continue at least 5 more years, but I imagine much longer, our presence in southern Karnataka. So in the next 5 years, we will focus around building this birth cohort, possibly the first birth cohort of Adivasi households in Karnataka, with Giridhar Babu and Suresh Patti in IIPH Bangalore. And with Deepa Bhatt, we are hoping to meaningfully impact hemoglobinopathies care, particularly sickle cell disease, G64PD, and thalassemia. And with Upendra Bhojani and myself and Tanya, we hope to try and convert these sports clubs into a sustained intervention that can build resilience at community level for young people, with respect to not only with respect to addiction, but also with respect to wellness, and also perhaps hopefully addressing various other psychosocial difficulties that they may be facing due to these due to historical issues. And secondly, another thing that Debarati mentioned, and where I have the privilege of being able to work with Sangath and several other wonderful organizations, is in Coincide. And the link here with studying early child mental health and development is to try and bring this understanding of wider social inequalities and how they impact within households, how the system sort of dovetails into individuals and households and brings about and drives disadvantage. So this is something that Smita will lead in Sangath and Eunice will lead in Bangalore. So with that, I think I really apologize. I went clearly 10-15 minutes beyond what I wanted to go, but I want to thank a lot of people who are involved in this journey. Some of them are pictured here and many of the others are named here. Back to you, Gauri.
So thank you so very much, Prashanth. I think this is, so for me, it's very early in the morning in the US, and it's absolutely energizing to hear this really fantastic, not only breadth, but also depth of work that you have done. You've done it in a way that is systematic, participatory, and I think, many of us use this word very loosely. Where we bring a few people from a community, into a focus group, and then we are proud to say that it's participatory. But I think, your work is really truly shown us in Sangath, which I think is the majority audience, I'm suspecting, but may not be, how we can really be pushing ourselves to really think about a more participatory approach. So let me thank you, first of all. It was just a fabulous walk through your really the breadth of the work, and there were so many things that I have questions on, and so many ideas about maybe how we could bring this together in the work that we do. But first, before maybe I ask a question, I'm just wondering, is there anybody in the audience who has any questions? Maybe you could just raise your hand. I can see Ravi was on the call. I'm not sure. Debrati, Smita, if there's anything. Yes, Debrati, please go ahead.
Thanks, Gauri. Absolutely fascinating talk, Prashanth, and I feel every time I listen to you speak, I understand a little more of the breadth and depth of work you do. It's mind-boggling. But my question to you, especially coming from the fact that we are also looking at health inequities in urban and rural households, how universal do you think adversity and health inequity is, and what you've learned about health inequities and how we can tackle them in terms of the interventions you've tried out? Do you think those interventions may also be universal and applicable pretty much wherever there is disadvantage?
Yeah, I would say it's too tall a question for me to answer comprehensively. But I think I can reflect a bit on the second component. I mean, universality of inequities, I think, is a very philosophical question. I think we should all probably just take back. I'm sure many of you are already. I think many of us, for me, it was a personal journey. Take, for example, on gender, and I often bring it up whenever we have this statutory annual gender, internal complaints committee requirement that is there in the law that all organizations need to have. And so we have this workshop on gender. And I think there's a moment where, at least as a cis male, when I feel like when I feel like my consciousness has begun to be raised about gender, and then you start seeing the same reality very differently, right? And until that happens, there was no gender inequity. I mean, I have been in, as a young medical student, I have been in debates where I have said, yeah, I mean, look at all of these feminists, making such a big deal and everything is equal, etc. But then you undergo some kind of an internal process, and then you realize, my goodness, how wrong I was. So I think it depends a lot. A lot of this has to be an internal reflection among academia and researchers on where have I raised my consciousness and where have I not. And I think in my interaction with several activists, some of them very adverse, I have begun to realize that this is going to be a lifelong journey. So I won't go further detail into this idea of whether inequities exist everywhere. I think it's about all of us embarking on that journey of how do I see the world, how and then practicing that, I guess. But on the interventions thing, I'm a bit cynical, I would say, about the idea of scale. I think it comes to us from very I hate to say westernized, but anyway, I mean, this high-income country institutions which with global health agendas who have to impact in 5 years, 10 years. You have a packet of money and then you want scale. You want, and then you want the best buys, and okay, what take something from here in Sudan and will it work in Somalia, etc. So I feel it's a very difficult question. Even in India, for example, I don't know what could work in Nagaland and will it work in Chamarajnagar? I really don't know. So I feel this idea of scale is a false problem. We must deal with systems working without there needing to be kind of smart interventions that need to be brought out from elsewhere. And at the heart of that is the ability of people to be able to hold systems accountable and where this is going. This is going towards governance and punch and things like that. But that's my view of, on that. I may be wrong.
Thank you, Prashanth. That was a terrific answer. I have many comments to make on that, but I know Ravi's waiting. But what I just want to add over there, to what you said, and I think this is, we need to, as individuals, start seeing our own privilege. And I think you brought that up briefly. There is also this idea of social capital. We say people are poor, but actually, we may not be cash rich, but the amount of social capital many of us have come to the table with, which, disadvantages people who don't have a voice, particularly indigenous communities who are not even considered whether they can sit on the table, let alone do we invite them into the room. And so I think each of us in these, I would say Sangath is also in some ways a kind of ivory tower in itself. How do we start really, interrogating these advantages that we have when we go into communities, I think would be an important step individually. And I think you've really described it very nicely, that this is a lifelong process. How are we going to move through this as individuals, but also as organizations? Ravi, can I hand over to you for your question?
Am I audible, Prashanth? Yeah, okay. Yeah, thank you. So I have an apology to make, a compliment and a complaint. So apology because Prashanth, I was supposed to be introducing you. Unfortunately, there was a goof up and many of us were waiting on a Zoom link. And by the time we came here, you were already underway with your presentation. So apologies for that. But anyways, because I was supposed to introduce you, I have gone through your CV and I'm intimately familiar now, probably more than the others, with your work. So yes, you have already got a fan in me here. So I was listening to your, and I was thinking about is when you mentioned about power, like when it comes to the communities where the research is being done, how much of emphasis is done also on respect. It's not about the power which we have, but also whether we go in with a respect that that these communities where we are going to be doing research, and sometimes what also happens is there are some incentives being given so that the research is a little more smooth, but whether respect to that person who's in the participated research is whether that is considered. So that's the kind of thing which I wanted to check. And I was left wondering, I mean, as I was kind of understanding, I was wondering is whether, because I have not done research in the areas in which you work, whether there is a mechanism for an equivalent of what we call a tribal ethics committee, so a kind of a group of people like you talked about Sangath, whether they actually do screen whenever somebody wants to do research in this community, whether they screen and say, what, this is not suitable, or we cannot approve, or do go back and modify your project. So that was the comment, and the complaint was that your presentation to me was too short. because this the concept of equity is difficult to grasp. I mean, as you were saying in the debate, I also remember getting into those debates when we were much younger students, and then talking about merit and saying everything is equal, and it took a long time for the concept of equity, and that's the kind of topic which you have been talking about needs to be very slowly chewed upon and understood. So maybe, I mean, my personal thing is that we need to meet more often and understand what you have to share. Over to you. Thanks.
Thanks, thanks, Ravindra. On the idea of respect and dignity, I think it's extremely important, and also in the case what we have learned over time, also in the context of healthcare services. I mean, I did medicine in a government medical college in southern Karnataka, one of the oldest in Karnataka, in fact. And I have been on the other side as a provider in the government, and I mean, even now things haven't changed, and I mean, although buildings and infrastructure in Karnataka at least have improved, the idea of dignified healthcare is still really a dream in not only in government, perhaps in many private facilities as well. Now, in the context of research, I mean, to close that, so this is an agenda that we are keeping, and that's why I think Meena and Madhavamma's, which I mentioned on healthcare experience. How does an Adivasi person who is referred under, because everything is free, everyone now says, things are free, it's fine, then you have to just show up and show your BPL card, everything is free. So it suddenly feels like, oh, this is now seamless for everyone. It's not the case. The kind of barriers that they still exist to be able to convince people is dependent on the adverse healthcare experience that they have heard of. They hear these stories of others who have been to Bangalore or Mysore, and how they have been treated, how they have been spoken to, etc. So, and the fact that in a new city, social networks do not exist. Gauri was mentioning about social capital. If you are one of the 12 forest-based Adivasi communities in Karnataka, it's very unlikely that there is anyone in Mysore or Bangalore. So it's literally like being referred to Delhi from a village here, So that's altogether some piece, and that's ongoing work. But in the context of research, I think to reflect on how can we better practice respect and dignity in research, I think the only way is if the research agenda too is locally constructed. I know that's very difficult in the context of grant writing, for example. I mean, we are living in a kind of an environment where grants are literally have to be written in a matter of weeks, and they are largely leveraging bright ideas. They are not leveraging long processes. But the kind of work I'm talking about needs to incentivize long process. I mean, researchers grant making needs to say that, okay, unless you demonstrate a long process of engagement, we will not get this grant. Only then will researchers like us actually try to do that. Otherwise, there is no incentive to eat slow cooked food. I mean, everything is quick, fast food. So that's a quick comment I had. I don't know whether it fully addresses your question.
Thank you.
Thank you, Prashanth. I've got Abhijit next. Abhijit, please.
Thanks, Gauri. Thanks, Prashanth. A very interesting presentation. I mean, needless to say, people have been kind of putting so many compliments in the chat box, so I don't really have to say that anymore. So I don't have any high-level philosophical question for you. I have a pretty pedestrian, programmatic question, because one of the things that you kind of spoke about in the lot of the work that you have done is about the sports-based intervention delivery, or the sports-based programs with the volleyball clubs, and that intersects with some of the work that we have been doing for a couple of years now with a plan of kind of testing that intervention, and which is looking at substance use and prevention of substance use in young people using a sports-based platform. So it'd be interesting to hear your kind of experiences on this program in terms of what are the kind of challenges to expect in terms of integrating this kind of program within communities. What makes it more acceptable? What are the things on which you get pushback from the community or the parents of the young people, etc. So some of your experiences would be greatly helpful for us when we design our program to go to the next level.
Sure, thanks, Abhijit. I believe I might follow some of your work on Twitter. I think I've seen your Twitter handle on sports and mental health. So I don't think we are at a stage where we have too wide lessons to offer. It's very small. The total number of people I think who are involved in our intervention are about 110 to 120 young people, of which about 70% to 80% are male. They are all in the age groups of 16, 18 to 28, 30, and compared to I mean, I can quickly share. We can have a separate conversation perhaps, but for this space, for me, what was illuminating is that within a forest-based Adivasi context, there are several specificities that come into play with respect to sports and wellness that may not be the case elsewhere. For example, the community is homogeneous. It's one tribe that we work with. Of course, the idea of one tribe is the word tribe has its own contestations, which I said we will not deal with today. But within the same Adivasi community, of course, you can have so many different intersections of identities. And one of the difficulties is that creating public spaces and claiming them has always been pushed back. So historically, the community has been penalized for owning public space. So this becomes a kind of a community level psychosocial barrier to be able to navigate when you ask them to come together and, you know, even for example, scream and play and enjoy, because part of the sports thing is about you scream, you enjoy, you fight or whatever, you know, all of that. It's very subdued. So we need to also you know, try and work with the administration, with the forest department and others. There's always all kinds of complaints coming about, you know, collectivizing people that one has to face. So this may not be the case in a heterogeneous peri-urban rural context. Second thing is that harmful use. I also, because I'm not trained in mental health. Of course, I mean, I did some kind of training that is available for non-psychiatrists online, etc. But there's a lot we need to do with respect to providing services that are there. Take, for example, Taluka hospitals in southern Karnataka. Taluka hospitals cover nearly 200,000, 300, up to 500,000 people in Karnataka, and you do not have any meaningful cessation services. Counselors are there. Counselors are splintered across programs. The HIV program has one counselor, and there will be some other mental health, Mano Chaitanya, another program who has its own counselor, and they're not available and accessible. So even in district hospital, tobacco cessation services are just, I mean, I won't even talk about it. So there's a lot of work that also needs to happen medically on this. Forget the community-oriented things. So in an ideal world, a sports-based intervention leverages and integrates and connects very well to a facility-based intervention. So our struggle currently is that there is nothing facility-based. So I wonder, and I think in the coming years, we are going to navigate and understand how do we deal with this. You know, you create these sports clubs and these small spaces where people come forward, and then what is the help that we can offer? So that's going to be the challenge. I know it doesn't answer your question, but that's where we are.
Thanks, Prashanth. Very useful. Maybe we can connect separately to kind of discuss these things in more detail and potential collaborations.
So thank you. So first of all, I had a warning that says I have 3 minutes left on this call. So before there's some other kind of disaster of cutting everybody off, we can continue the conversation if the thread continues. But, before we close, first of all, I really want to thank you, Prashanth. This was really a fantastic talk. I think all of us from Sangath, I know there are many other guests here on the call. We've had, at least personally, I've had just so many ideas of things that, okay, here's a good intersection, here's a good intersection, here's a good learning. And I think one of the things that you brought up, which was this idea of accompaniment, which I know Vikram's previous mentor and lead of the department, Paul Farmer, talked about a lot. That how do you accompany people through their service, experience with respect and with knowledge. So that this idea of a health service being intimidating and frightening is taken away. And it comes to this fundamental issue, I think, in the context of the world, but I think very acute in India, that we are so quick to other. Anybody that doesn't look like us, doesn't talk like us, doesn't dress like us is somebody else. And I think, sadly, the health system in India is the epitome of these wonderful habits. We're just trained to other because we think as doctors we're right on the top for some reason. So I'm really going to, just say that I sense that many of us in Sangath would like to maybe reach out to you individually. Personally, I've just been writing down all the articles that you quoted and saying, oh my God, I think I just need all these, publications in my inbox, so that I'm hoping maybe Smita could just curate that with you a little later, so that people who attended this call could maybe have access to these publications. I'm also just going to plug a book, which I think it gave me a really wonderful idea. It's a youth novel, and I don't know, Prashanth, if you've read it. It's called Year of the Weeds. It's written by Siddharth Sharma, and it's on the Niyamgiri movement from Orissa. And it is this fabulous little book which really puts you in the shoes of a tribal youth. And, the kind of abuse and misuse the system on a daily basis, gives you, and how it's so internalized. You finally just start thinking, okay, I have no value in this community. And it is, it's written for young people, and I think, it's a great book. So I really hope that, some of you in the audience, can actually pick this book up, from Amazon or wherever you buy a good book. But let me conclude, because it is 8 and the link is absolutely going to slam down at us. Prashanth, thank you again so much. I'm also going to wonder whether, on a kind of smaller capacity building space, in Sangath, we could reach out to you and your team on some of the work, components of the work you've done, to maybe talk, from researcher to researcher groups on how we could capacity build within Sangath to really gain some of these skills. So thank you very much again. And, I hope this, I mean, it's just a delight that we are working with you on Coincide. And I'm hoping that we can continue these conversations over the next many years. So thank you.
Thank you.
Thank you all. Maybe Jolene, if you're still around, I could just, I don't know if Jolene is on this call.
No, she's not here.
Okay. So maybe Smita, just some conversation by email about what really happened in the beginning would be really quite nice to understand. Thank you, everybody. Have a lovely day or evening, whichever time zone you're on.